Now I'm going to try to give you 3 cases to try to convince you that this is worth remembering. They're all real. Okay, here we are, 24-year-old girl. She got GCS of 3 in the emergency department. With pH, you can see that for yourself, how sick she is. And I got a phone call from the anaesthetist down there saying, got this girl, GCS is less than 3, I'm going to plan on intubating her. What do you reckon? GCS less than 8, must intubate? Yes? No? The problem is, let's look at her acid-base compensation. 5th of the bicarb, so 5th of 8 plus 1 is around 2.6, she's 2.5. Spot on the money. And young DKs, you'll see them over and over again, they'll either be on the money or actually got a respiratory alkalosis on top. She's doing everything you can to achieve the perfect CO2, the perfect appropriate compensation. Nothing to do with the pH. Some people would look at that and go, well, she's not compensating properly because the pH isn't normal. That's garbage acutely. What you've got is the fact that she's appropriately compensating for that degree of metabolic acidosis. Is it easy to ventilate someone down to arterial, not even end-tidal, CO2 of 2.5? And the answer is no, not at all. The moment her CO2 starts to rise, as you give her some cryo sucks, intubate, try to bag her, the moment her CO2 starts to rise and fall outside of that rule, she'll now have a respiratory acidosis, a mixed picture, metabolic acidosis and respiratory acidosis. Her pH will drop further and she might die. And patients have died from this before. Even recently, someone was sharing a case when the advice given in this very, very severe acidosis was to try to normalise the CO2 up to around 4. And why are you hyperventilating the patient? They were hyperventilating like crazy to try to maintain a very disturbing thing. What I did with her, it's a senior call. I went down, tried to resuscitate her with fluids, did an intubator, watched and see. She woke up, didn't even come to intensive care, went to medical HTU. Now that's not easy. There's a risk of aspiration. It's not an easy call. But the rule gave me the confidence that she was doing exactly as she should be, and therefore I would just be safer just to observe and treat. I didn't go away and leave her. I stayed with her until she was well. As patients have died when their CO2 rises. Take the second example. This was another young girl. She was in the emergency department. Got a phone call going, oh, do you think you can maybe come down and see what this really sick girl, she's got DKA, you can see that glucose is off the scale, we're a bit worried about her. I go, yeah, sure, what's the bicarb? Because they told me the pH 6.9, what's the bicarb? Well, they didn't know, of course. They went pitter-patter, came back to 10. And I went, 5th of 10, it's 2 plus 1. What's the CO2? And they went, oh, I don't know. Why they didn't bring gas, but anyway, pitter-patter. And they said 4.5. And I said, I'm coming straight down. And there was no sense of urgency from me in the ED, because I could just very quickly see that she should be 3, and she's 4.5, and she's young. And 4.5, they thought 4.5 was pretty good because she's trying to compensate, was with the words probably what's going through their mental process. She's trying to compensate, and because the pH isn't normal, and they're getting it all muddled. This girl is peri-arrest by definition because of this. And we did end up tubing her, and the anaesthetist who was helping me, quite senior, so it was difficult intubation, and then we actually gave bicarb, which is very controversial, but I often find myself using it. pH is less than 7. And then basically was, then we could bag her very easily. And in the end, what turned out, she had staph pneumonia, and she ended up going to ECMO, and that was a new presentation of DKA. The thing about the rule, though, is it told me in advance and told me earlier than anyone else how sick she is, and it's not very hard. Okay, third case. So a couple of years back, probably 5 or 6 years back, someone was in this room like you are now, went off then to the wards and elsewhere, and was seeing an elderly male where her senior physician said, oh, look at that CO2, this has to be a PE, organise a CTPA. And she said, Dale says a 5th of the bicarb plus 1, and a 5th of 5 is 1 plus 1 is 2, and he is 2, and he's old. There is not a single thing wrong with his respiratory system. He cannot get down to a CO2 of 2 and B, have a problem with your respiratory system. It's clear, and there are probably lots of other reasons why this wasn't a PE, but off he went for his CT and he died of his sepsis in the scanner. And it was very clear that what he had, it was nothing to do with a PE by very definition of knowing the rules. So where are we on metabolic acidosis? Hopefully you've got a new nomenclature. Save the word emia for the pH, and then look for the osis that's causing that pH disturbance. But think of osis in terms of the pathological process. If you ever see the bicarb and CO2 going in different directions from the normal, it's clearly a mixed process straight away. And that should tell you there's two pathologies happening that I need to address. And then you can use the rule for appropriate acute compensation. And that's what the Boston rule gives. It's a fifth of the bicarb plus 1. It's in MedCalc. Right. Now I'm going to talk about the causes of metabolic acidosis. How do you divide up the causes? How do people like to divide up the causes? Anyone?
Based on the anion gap.
Anion gap? Yeah, I like the anion gap. Anyone else know anything else? Never give me mud piles. Everyone heard of mud piles? As a mnemonic for metabolic acidosis, your first answer is methanol. Like if anyone ever got me an exam, I said, what's the cause of metabolic acidosis? I mean, how many methanol poisonings have you seen?
No.
I think I've seen one or something like that, and it wasn't even a bad one. And so, to give your answer in an exam, your first answer is methanol, you'd say, come back next year. So, what are the causes of metabolic acidosis? Anion gap is the most helpful. In our hospital, it's quite complicated what blood gases are doing. It's not quite fixing into any of these sort of simple rules. There's obviously some fudge factor that you can't quite work out. They certainly aren't including potassium. So around 12 is probably the cutoff between a high anion gap and a normal anion gap acidosis on our blood gases. So you see there's quite a range in that. What you may not appreciate, in high anion gap acidosis, what you've got is an extra anion. And that anion often ends in 8. So what happens is the anion, the negative charge, enters into the system, and then other steward, the body doesn't want to be a battery. So we've got two choices, increase the positives or reduce some of the negatives. And since bicarb is so easy for the body to get rid of, bicarb goes down, you get an acidosis. So tell me some 8s, some anions, 8s that can cause metabolic acidosis. Lactate, yes. Give me another one.
Salicylate.
Salicylates, all the poisons. Any other poisons?
Urate.
Urate?
Phosphates.
So that's,
Sulfate.
they're not really so much poisons, but when do they come?
Poisons.
When do they accumulate?
Renal failure.
Renal failure. So in renal failure, you have fixed acids you must weigh out every day. Otherwise, they accumulate and give you an acidosis. And they are urate, phosphate, and one other? Sulfate, also known as uric acid, phosphoric acid, and sulfuric acid. Give me another cause or another poison. So, xanthine, yeah. I can't remember what that breaks into. Probably xanthamate if it follows the rule. Anyone else? Diethylene glycol, glycolate. Tell me, you missed a big category. 2 of my patients had that disturbance.
Ketone.
Ketones. Name a ketone.
Beta-hydroxybutyrate.
Butyrate. Well, name another one.
Acetoacetate.
And acetate itself. So there are 3 ketones, all end in 8. So what you've got here is lactic acidosis, ketoacidosis, renal failure, and the poisonings. And methanol breaks to formate, ethanol to acetate, and we've got pyroglutamate, and there's others as well. So it's very, very simple.